Hello, and thank you for joining us for this Target Oncology presentation titled Targeting KRAS Mutations in Advanced Non-Small Cell Lung Cancer. In non-small cell lung cancer, the most frequent oncogenic driver or mutation is KRAS, and there are not currently any approved targeted therapies yet. I think today we'll learn about some of these new agents that are coming about, and we'll talk about the recent advances in KRAS mutant non-small cell lung cancer with a focus on these new therapies. I'm Dr. Benjamin Levy. I'm an associate professor at Johns Hopkins School of Medicine and clinical director of the medical oncology unit at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Joining me today is Dr. David Gandera, professor of medicine and senior advisor to the director at the University of California, Davis Comprehensive Cancer Center in Sacramento, California. David, thank you for joining. It's a pleasure that we're able to do this together. Let's begin.
There's been, of course, a tremendous change in how we diagnose and reach treatment decisions in patients with stage 4 non-small cell lung cancer. And maybe more than any other type, biology has led the way in non-small cell lung cancer. So can you comment on how this has led to improved outcome? For example, let's start with targeted therapies.
Sure. I mean, I think you stated it well. I think lung cancer has been on the leading edge and has been the poster child for precision medicine. You know, I got into this field just 12 years ago, and that was at the point where EGFR was being discovered as a relevant, actionable mutation in non-small cell lung cancer with the IPASS data. And we've come such a long way in the past decade, 15 years, with a better understanding of genetic alterations that define distinct molecular subsets. There was a course came along ALK several years later, and then the list continues to grow since then with ROS rearrangements and MET exon 14 skipping mutations and RET rearrangements and HER2 and all these other alterations that importantly define these molecular subsets that now we can wed to targeted therapies that are selective against these particular protein products of the mutation. And as you're aware, and you've led some of these studies, David, is you know, we've improved outcomes with these targeted therapies when we give the right drug to the right patient. So my running joke is I went into lung cancer because it was easy, and it is becoming extraordinarily complex. I guess there's always been a great degree of complexity with treating any tumor type, but we've come a long way in defining these distinct molecular subsets and developing targeted therapies that have certainly improved outcomes and improved, importantly, probably underrepresented in the literature, quality of life, and also drugs that do a great job crossing the blood-brain barrier. So it's an exciting time to be in the field of lung cancer right now.
Well, thank you, Ben. It's interesting. I haven't heard you say this before, that you went into lung cancer because it was easy. I went into lung cancer because it was difficult. I looked at this as a challenge. And I'll just say during the presidential address at ASCO, when George Sledge showed the TCGA data on mutation rate, and he compared all the different cancers, and he said, down here with low mutation rates, we have pediatric cancers and we have hematologic malignancies. No wonder they're so easy to be treated. And he said, over here at the far end, you see melanoma and non-small cell lung cancer. Those other cancers are stupid cancers. These are the smart cancers.
True.
I think the fact that you say we've made advances is even more impressive because this is a smart cancer.
Yes, indeed, indeed.